I am Leema Rosemary, Assistant Professor, St.Joseph College of Arts and Science, Cuddalore. Now I am going to talk about pulmonary tuberculosis. Tuberculosis is a chronic granulomatous disease. It is a major health problem in developing countries. About 1/3 of the world population is infected with Mycobacterium tuberculosis and Mycobacterium bovis. This disease can affect any organ in the body. However, the lungs are affected more commonly. Infected tissue is invaded by macrophages and later it becomes fibrous. Affected tissue is called tubercle. Tuberculosis was once considered to be an incurable disease, but nowadays its effective chemotherapeutic agents are available for its treatment. These are the classification of tuberculosis drugs. According to their clinical utility, the anti-tuberculosis drugs can be divided into two groups. First one, primary or secondary drugs. Second one, secondary or reserve drugs. Primary drugs. These drugs have high tubercular efficacy as well as low toxicity and are used routinely. Secondary drugs. These drugs have either low anti-tubercular efficacy or higher toxicity or both and are used as reserve drugs. Some example for primary drugs. Bactericidal example, isonicotinonic acid hydroside, rifampicin, pyrazinamide, streptomycin. Bacteriostatic example, ethambutol. These are the secondary drugs. Bacteriostatic, some example, para-aminosalicylic acid, thiacetazone, ethinomide, cycloserine. Some example for bactericidal secondary drugs are capreomycin, ganomycin. It is the most effective drug used in the treatment of tuberculosis. Isonicotinonic acid hydroside. Most active drug for treatment of tuberculosis. It is freely soluble in water. It is bactericidal for actively growing tubercle bacilli. Less effective against typical mycobacterial species. Penetrate into macrophages and is active against both extracellular and intracellular organisms. This is commonly known as isoniazid. The mechanism of action of isonicotinonic acid hydroside. First one, inhibition of phospholipid synthesis and damage to cell membrane. Then second one, chelation of intracellular and extracellular divalent cations. Then third way, inhibition of the synthesis of RNA and DNA. And another function, inhibition of various oxidative enzymes. These are the structure of Mycobacterium cell wall. This is the layer of mycocyte, then mucoleic acid, then another layer arabinoglycan and peptidoglycan. These are the cell wall of the Mycobacterium. Here isonicotinonic acid hydroside inhibit mucoleic acid synthesis. Then another example, ethambutol, also it inhibit arabinoglycan layer. Then absorption, fat and excretion of isonicotinonic acid hydroside. It is well absorbed on both oral and parenteral administration. It is distributed in all body tissues and fluids including cerebrospinal fluid. It is mainly metabolized in the liver by acetylation. It is almost completely excreted in urine within the 24 hours, within a day. Then adverse reactions. Adverse effects are fever, malaise or jaundice, peripheral neuritis due to pyridoxine deficiency in an important toxicity, central nervous system effects like convulsions and psychosis, epigastric distress, dryness of mouth and urinary retention. What are the doses of isonicotinic acid hydroside? Such as tablet form, syrup or injection. In maximum 3 to 5 mg per kg by oral or parenteral route. The next example, rifampicin. So rifampicin also best example for primary drugs. It is a semi-synthetic derivative of rifampicin B. It isolated from Streptomyces mediterranae. It is a bactericidal and well absorbed on oral administration. It is widely distributed in tissues. It is metabolized to diacetyl rifampicin. This metabolite is equally tuberculosidal and undergoes intrahepatic circulation. Mechanism of action. Rifampicin binds to bacterial DNA dependent RNA polymerase. It inhibits RNA synthesis. It also bactericidal for mycobacteria. It readily penetrates most tissues and penetrates into phagocytic cells. It can kill organisms that are poorly accessible to many other drugs. Adverse effects. Hepatitis is the major adverse effect of rifampicin. Also it produces skin rashes, eosinophilia and leukopenia. Rifampicin impacts on orange red color to urine, sweat, tear and other secretions. Dosage form 10 mg per kg daily by mouth. The next example, streptomycin. It is an aminoglycoside antibiotic. It is obtained from Streptomyces grisas. Antibacterial activity of streptomycin is mainly effective against gram-negative organisms. It is bacteriostatic in low concentration and bactericidal in high concentration. The sensitive organisms are Mycobacterium tuberculosis, Escherichia coli and Streptococcus pyogenes and Streptococcus faecalis, Streptococcus viridans. These are very sensitive to streptomycin. Then mechanism of action. Streptomycin combines with bacterial ribosome. This prevents RNA ribosome combination. Streptomycin induces bacterial ribosomes to synthesize wrong amino acid and proteins. It also inhibition of some enzymes like xanthine oxidase. Streptomycin is poorly absorbed from the gut, so it can be used as an intestinal antiseptic. It is well absorbed on intramuscular injection. It diffuses into all body fluids, cerebrospinal fluid, but high concentration in cerebrospinal fluid is achieved in presence of meningeal inflammation. It is partly metabolized in the liver. Elimination is through kidney by glomerular filtration. Adverse reactions of nausea, vomiting with oral streptomycin, abscess and fever, intolerance in the form of skin rashes and blood dyscariasis. Eighth nerve damage is an important toxicity. It leads to loss of equilibrium and deafness. Renal failure like albuminuria and cylindriuria. Superinfection with candida leading to endocarditis. Preparation and dose. Streptomycin sulfate tablet as a tablet form and syrup also. Daily dosage form 0.5 to 2 gram and injection form 0.5 to 1 gram per daily. The next example, pyrazinamide. It is chemically related to nicotinamide. The efficacy of pyrazinamide is increased when combined with isonicotinic acid hydroside. Pyrazinamide is all well absorbed from the gut and it is widely distributed in all the tissues. Toxic hepatitis is serious adverse effect for this drug. Dosage 20 to 35 mg per kg. Mechanism of action. Pyrazinamide enter into the Mycobacterium tuberculosis by passive diffusion and is converted into pyrazinoic acid by bacterial enzyme pyrazinamidase enzyme. The active metabolite then inhibits microbial fatty acid synthesis 1 enzyme and disturb mycolic acid synthesis needed for cell wall synthesis. This is the mechanism of action. This is the structure of cell wall polysaccharide. Pyrazinamide inhibit the pyrazinamidase, this enzyme. Then next example, ethambutol. This is also the bacteriostatic drug. It is the standard drug, that is primary drug. It is used as a substitute for para-aminosalicylic acid. It is effective against Mycobacteria resistant to isonicotinic acid hydroside, para-aminosalicylic acid and streptomycin. It is absorbed after oral administration. The adverse reactions are optic neuritis and peripheral neuritis. Dosage 15 mg per kg per day. Mechanism of action. Ethambutol inhibits polymerization of arabinoglycans of cell wall by inhibiting arabinosyl transferase enzyme. The next example, para-aminosalicylic acid. This is also bacteriostatic drug. It is one of the primary drug. Para-aminosalicylic acid is a synthetic compound which is less potent than streptomycin or isonicotinic acid hydroside. It related to sulfonamide, completely absorbed by oral route, distributed in all body fluid except cerebrospinal fluid. And the dose is high 10 to 15 days daily. So it is a rarely used now. Diastosone. It is a thiomycarbazole derivative, low efficacy drug. It is used with isonicotinic acid hydroside or as a substitute for para-aminosalicylic acid. It is orally absorbed. It crosses placenta and also it is secreted in the milk. The adverse reactions are fever, skin rashes, dermatitis, anemia, liver and kidney damage. The next, secondary or reserve drug. First one, capreomycin. It is a polypeptide antibiotic obtained from Streptomyces capreolus. It is inactivated in the gastrointestinal tract. So it is administered by parenteral route. It is effective against Mycobacteria resistant to drugs of first choice. Adverse effects are allergy, renal disturbances and eighth nerve damage. The next example, ganomycin. It is an aminoglycoside antibiotic obtained from Streptomyces ganomycetes. It is effective against Mycobacteria resistant drugs for first choice. It is completely absorbed from gut. Adverse effects are nephrotoxicity and eighth nerve damage. Ethinomide. It is chemically related to isonicotinic acid hydroside. It is effective against tubercle bacilli resistant to other drugs. It acts by inhibiting protein synthesis. It is rapidly absorbed from gastrointestinal tract. A significant concentration is present in cerebrospinal fluid. Adverse effects are allergic reactions, gastrointestinal symptoms and neurological disturbances. Next example, cycloserine. It is an antibiotic having tuberculostatic effect. It is well absorbed from the gut. Significant concentration is present in cerebrospinal fluid. The serious adverse effects are neurological and psych effects. These are the summary of the tuberculosis drugs. Already I have explained first line and second line, that is primary drugs and secondary drugs. The another example also, amikacin, capreomycin, ciprofloxacin. So many new examples. Thank you.